This time we're going to talk about the rotator cuff. And the rotator cuff is a formation that encloses and strengthens the joint of the shoulder joint. So if we look at the humerus, and this would be the glenoid cavity, and here we will have the clavicle and the acromion. So we are looking anteriorly at the shoulder joint. We will see that the shoulder joint consists of the following. We have the head of the humerus, and it's covered by a cartilage, and also the glenoid cavity is covered by a cartilage. And in between here we have the synovial fluid, and there's a superior ligament and an inferior ligament that holds the two structures together. And that's it. How to support such structure? Now, in this case, the joint will be very weak, so this rotator cuff will enclose the joint from all directions except from below. So we have it above, and on the other two sides we have muscles that form the rotator cuff. On this view we can just see one of them, which is the supraspinatus. So it comes like this and it attaches here. So this is the supraspinatus muscle, and of course here we have the deltoid. Here we have the deltoid muscle. Now, what is the clinical significance of this structure, the rotator cuff? Here on the humerus, at the level of the surgical neck, we will have the course of the axillary nerve. And on the middle of the shaft of the humerus, here we will have the radial groove on the posterior side. So we will have the radial nerve that will course in the same direction with the deep brachial artery. So both these nerves will be affected if a dislocation of the humerus happens. And this dislocation will happen because of an intensive extension or abduction or adduction, and it happens this way. We said that the rotator cuff surrounds the shoulder joint from all directions except from below. So the bone will move downwards, and then it will go to the front and move above again, or move up again. And this is how the dislocation happens. Now we will see how the cuff encloses the shoulder. So we will have a view as a cross section to this side. So it will look something like that. This would be the clavicle, and around here is the acromion, and here is the coracoid process, and this is the glenoid cavity, and that would be the body of the scapula. So we're looking at this side. At that level, here attaches the superior ligament for the joint, and here we have the inferior ligament for the joint. Now, where does each muscle insert? So on the upper side we will have supraspinatus. And then here we will have infraspinatus. And around here we have teres minor, and on the other side here we have subscapularis. Now, as we can see, there are no muscle insertions at that point, and this is where the dislocation happens. So the bone goes downwards, moves to the front, and then moves upwards again, and this is the mechanism of the dislocation. It's easy to remember the names of the muscles that form the rotator cuff because we can remember them from this word, sits. So supraspinatus, infraspinatus, teres minor, and subscapularis. Now, a final note about the radial nerve and the axillary nerve. We mentioned that they can be affected at the dislocation. Also, they can be affected by fractures because we said that they are found on the course here, the axillary nerve at the surgical neck and the radial nerve at the middle point of the shaft of the humerus. So if a fracture happens at the level of the surgical neck of the humerus, the axillary nerve will be affected. If a fracture happens at the middle point of the shaft of the humerus, the radial nerve will be affected, and the radial nerve affects the innervation of the rest. So if there is a lesion or the radial nerve is injured, it causes a rest drop. So this is a sign for a problem that occurred in the radial nerve. I hope the rotator cuff structure and muscles were clear, and that's it for today. Until the next time, I thank you for watching and see you.